Good evening, everyone. Thanks for joining us for this Tuesday TIF Talk. I am your host, Wendy Profit. Along with me, we have Lynn McFadden from Endogastric Solutions, and it is our pleasure to have Dr. Tamer Sargios joining us this evening. I want to tell you a little bit about Dr. Sargios. He is a clinical assistant professor of medicine at New York Medical College in Valhalla, New York. He's an associate director of gastroenterology at MidHudson Regional Hospital of Westchester Health System and a board-certified gastroenterologist. Dr. Sargios specializes in the diagnosis, treatment, and prevention of gastrointestinal diseases with special interest in advanced procedures. Dr. Sargios studied medicine at Ain-Shams University School of Medicine in Cairo, Egypt, and completed his residency and fellowship at Beth Israel Medical Center in New York City. Dr. Sargios has offices in Poughkeepsie and Fishkill, New York, and performs the TIF procedure at Vassar Brothers Medical Center in Poughkeepsie. Welcome, Dr. Sargios.
Hi, Wendy. Thank you very much for having me.
Thanks so much. So to our viewers this evening, as we do each week, I want to remind you, please go ahead and put your questions regarding GERD symptoms in the comments box. Lynn will be taking a look at those and getting them to Dr. Sargios throughout the conversation as we're able. Appreciate everybody being here. Dr. Sargios, let's go ahead and jump in. If you could, please tell us about GERD, what you see in your practice and the disease process itself.
Well, GERD is it's a very common disease, and it's very prevalent in the general population. Everybody have experienced some sort of reflux or acid indigestion at some point, which is not what's GERD about. But GERD is actually a disease when that episode of acid reflux becomes out of control or becomes repeated. So GERD stands for gastroesophageal reflux disease, which is when the acid in the stomach reflux or come up in the esophagus. Not only the acid, but the content of the stomach when they come up in the esophagus and or all the way up to the mouth. Occasional reflux is normal, but when it happens frequent and out of control, then when it becomes a problem. People with acid gastroesophageal reflux disease experience many different kind of symptoms. And it goes from a little bit occasional heartburn to frequent heartburn to feeling indigestion frequently to feeling difficulty swallowing to variety of symptoms that sometimes end up in the lab of the heart doctor. My practice, I see probably close to maybe 40% or even I can dare saying half of my practice people who have some sort of symptom related to gastroesophageal reflux disease. So it is very common in our population, especially in the Western countries.
Wow, 50%, goodness. So something that I'm curious to know is we've started hearing people cough and sneezing a little bit more as March has arrived, and a little bit of reading that I have been doing talks about some of the atypical symptoms of GERD, not just your standard chest pain, et cetera, but more toward the asthma side. Can you talk a little bit about, just adult onset asthma symptoms and how those can potentially, mirror what GERD is?
Sure. So not everybody who have GERD or acid reflux disease has atypical symptoms like you're saying, although it's most common to have the typical heartburn, regurgitation, food comes up and down in the throat, bitter taste in the back of the throat and the back of the mouth, especially after heavy meals or when bending over or when lying down flat, especially at night, interrupted sleep, and so forth. So that's kind of the typical symptoms of acid reflux. If you go to the atypical symptoms or the unusual symptom of acid reflux, which sometimes makes people go in different direction rather than coming to the gastroenterologist as a first step are symptoms like chest pains. Some people feel like, oh, this is a heart attack. And they go and they see different kind of doctors. They go to the cardiologist or the ER and they find nothing, so they can send to us. Some of the other symptoms, like what you mentioned, is pulmonary symptoms or upper respiratory tract symptoms. The asthma feeling, wheezing, coughing, having clearing of the throat frequently, changes in the voice, hoarseness of the voice, and particularly cough. They end up going to the pulmonologist or the primary and getting diagnosed with asthma, get put on different kind of asthma inhalers and allergy testing and so forth. And some get better, some don't get better. And the one that don't get better, then by digging more in symptoms, they found there might be some related heartburn or indigestion, and then they get sent to us as gastroenterologists. So there is an entity of relationship between adult onset asthma and gastroesophageal reflux disease. Many people, many adult onset asthmatics, if you review them and you discuss with them their symptoms deeply, you'll find that they have some sort of GERD related symptoms, and you can diagnose them with GERD. And vice versa. Many people who have GERD, their asthma can be uncontrolled or hard to control if you do not control their GERD symptoms.
Thank you. So how do your patients tell you they've attempted to manage their symptoms, and what are your recommendations to them for managing GERD?
So, I mean, as a specialist, people come to me usually have tried many options. First is to try to manage it on their own with Tums and with over-the-counter medications like there are 3 different groups of medications over the counter that helps people with acid reflux. The first group is the Tums, which are basically antacid. So the Tums goes in and it just try to balance or buffer the acid produced in the stomach. And a lot of people come, they're already popping Tums right and left. Some when they feel symptoms, and some becomes routine in their day, that if they don't take it, they really feel bad. Some of them already have tried the next step up, which is what we call the H2 blockers, the over-the-counter Pepcid, Pepcid Complete, Pepcid AC, the what used to be Zantac, that's not in the market anymore, the Axid, the Tagamet. These are called the H2 blockers, which is group of medication that block the acid production or the acid release into the stomach. And nowadays, over the last several years, when we have now the PPI or the proton pump inhibitor, when they became generic on the shelf, like the purple pill, the Nexium, the Prilosec, the Omeprazole, all of this group of medication now over the counter, and many people already went to their grocery store and got a 2-week supply of those medication and tried them. Many of them, the symptoms gets better and they are okay, but when they see that they cannot take it more than 2 weeks at a time, because that's how the labels are, and then they seek advice. So that's how they come to me. They have come to me, most of them already tried many of the over-the-shelf regimen. Some got better, and most of them have recurrent symptoms after they stop the medications. And many already search online for kind of the complications, and they are worried about what the long-term effect of this is. That something really going to affect my life or no? How do I help them initially? I mean, as any disease, we go through elaborate review of what their lifestyle is like, or what do they eat and drink. And unfortunately, we don't like to change our lifestyle. It's not easy to change, and it's, even if you change it, it's not easy to adhere to for a long period of time. But I think this is the first step, and few people get better just by switching the way they eat, how much they eat, cutting down some of the food and the drinks that can make their acid production worse and can make their acid reflux worse. Not to eat late at night, not to eat and sleep, not to eat and lie down, not to eat and exercise, cut down the heavy food, cut down the heavy drinking, the soda, the sugary drinks, the fatty meals, tomato-based food, and so forth. And that helps initially. And then we take them for, it depends on how their symptoms are. Once they have symptoms frequent during the more than once or twice a week, and symptoms that affect their daily living and the quality of life, then we diagnose them with GERD as a disease. That's when we start looking for any of the risk factor for progression, or what we call it the high risk factor for advanced disease. And like elderly people, like people who have family history of esophageal cancer, people who have some of the alarm signs like weight loss, abdominal pain, bleeding, anemia. These are more than just acid reflux, simple acid reflux symptom. And these are the ones that need to be taken more testing and evaluation to make sure if it is GERD, that it did not go into further complications. Once we diagnose GERD and there is no complications from that, then we recommend the first line is to put them maybe on a longer period proton pump inhibitors. We start once a daily dose. The recommended dosing is usually in the morning, half hour before breakfast, at least 30 to 40 minutes before breakfast on empty stomach. It gives time for the medicine to act on and block the acid production. And then watch what we eat, and we'll be on some sort of regimented diet. Give them a month or so duration of treatment, and if they get better, then we'll continue on it. We'll try to wean off. If you cannot wean off the medicine, then you stay on the medicine as a first line. If the symptoms are not controlled, we double the medicine, and we'll go into either a higher dose once a day or split dose twice a day. Depends on if the symptoms are early in the morning or controlled and be recurrent late in the evening. So that's when we try to adjust the dosing of the medication. So that's like the first line regimen when people come to us who have not been on long-standing proton pump inhibitor or PPIs like the Nexium, the purple pill, the omeprazole, and all of those medications. As that's at the first line. Then we tend to recommend endoscopy after long duration of symptoms, if symptoms are not getting better, or if there is any alarm signs like the ones that I mentioned, then we recommend endoscopy, which is basically putting a camera from the throat down to the stomach. It takes 15 to 20 minutes to do the procedure. It's usually done under sedation. People do not remember it. There's no discomfort afterwards. It gives us a lot of information on the anatomy of the upper GI tract, the esophagus and the stomach. One thing it's important to know about GERD is it's not just the acid that comes up, but it's also the content of the stomach that comes up. And the reason for that is that there is a guarding muscle at the end of the esophagus that usually stay closed most of the time. If that muscle is relaxed or abnormally open most of the time, that's what brings the acid up in the esophagus. And the endoscopy will help us to look at that gatekeeper and see how abnormal is it. Is it abnormally open as we do the procedure and it's placed, or it's abnormally open and it's displaced higher up with part of the stomach sliding up on the chest, which is one of the reasons people have acid reflux, which is the hiatal hernia. So the two common reasons for people have acid reflux is or GERD is the valve that's weak, but it stays in place, and the valve that's weak and displaced and part of the stomach displaced in the chest. That's hiatal hernia. The hiatus is the opening in the diaphragm, which is the breathing muscle. And when it's displaced, that hiatus, when it's displaced or herniates into the chest, we call it hiatal hernia. So endoscopy, putting a camera down, will help us to evaluate the anatomy and the location of that valve or sphincter. It also will help us to see if there is any complications of acid reflux or GERD. And the complication of the GERD can go from ulcer in the esophagus, and that's long-term exposure of acid reflux or acid in the esophagus can eat through the wall of the esophagus and cause an ulceration. And that ulcer over time can heal by either scarring, which end up by stricture or stenosis or narrowing of the esophagus, which can make people have difficulty swallowing, or it can heal by abnormal cells. And those cells, when it becomes abnormal, that will become precancerous. And the precancer cells that comes up in the esophagus from GERD, we call it the Barrett's esophagus. So all of this kind of information we get by simply looking by doing the endoscopy. It's also important to make sure there is nothing else, like an ulcer in the stomach or cancer in the stomach or other reasons why people have those symptoms.
That's a great point. I think so many people, out there will definitely self-prescribe, try the medicines and stay on them, but there's always that thing in the back of your mind that unless you really have a look in there, you may be treating something that you don't have or do, for that matter. Thank you for that. That's so can you talk a little bit about what options are available beyond medicines for the treatment of GERD and actually I'm gonna back up for a second. You did talk about both I love how you talked about the muscle being the guarding muscle. That's brilliant. The other thing that a lot of our folks who see these programs wonder about is if you can have both GERD and a hiatal hernia at the same time, or are they mutually exclusive?
Right. So many people who have GERD don't have hiatal hernia. Okay, so they have normal appearing anatomy of the esophagus and the stomach in its place, but that guarding exit muscle or gatekeeper, or we call it sometimes the LES or the lower sphincter, that's just open. And those people don't have a hiatal hernia. And those people will not need a hiatal hernia surgery or hiatal hernia procedure. And on the opposite, there are a lot of everybody who have a hiatal hernia have some sort of acid reflux or have some sort of abnormal muscle. So the anatomy is unusual, part of the stomach slides up. So secondary to that, the muscle is in unusual position, an unusual shape, and unusual function. Okay, so kind of like most people, if not all people who have hiatal hernia will have abnormal muscle, but not everybody who has weak muscle will have a hiatal hernia with it. Okay, now it's something that we need to understand well, that taking medicine, it does not prevent the acid reflux. It does not prevent the reflux episodes. The medications will help blocking the acid. But if we have a weak muscle that's open or a hiatal hernia inside, there is still regurgitating fluid that comes up, whether it's acidic or non-acidic, and some content of the stomach will slide up. So that's why a lot of people who have GERD on medication and who have more than a very small hiatal hernia still have some symptoms. So that they tell you, oh, I take the medicine, my heartburn is gone, but I still cannot sleep at night because every time I sleep flat, I feel things coming up in my mouth and sometimes I choke. Okay, but my heartburn is gone. So what's gone? What's wrong? What's wrong is the valve is still open, or you have part of your stomach slide up in the chest. So when you go against gravity, the fluid is still coming up, and that's what's choking you, and that's what's causing you some irritation and changes in your voice, and not just the acid, but the fluid that comes up. That needs further evaluation.
That's a great way to describe what happens, because so many folks still don't necessarily connect the dots on what if I don't have that pain, but I'm choking and coughing, what is it that's causing that and how does it do it? So thank you for that. That's wonderful. So can you talk a little bit about treatment options for GERD beyond medicines?
So beyond medicine, so beyond medicine, what are the options? The option is to treat the cause, and the cause of the reflux, whether it's acidic reflux or non-acidic reflux, is those two anatomical problems: the weak muscle or the open valve, and the hernia. So if there is a hernia, fixing the hernia and restoring the valve anatomy and tone, the muscle strength, is basically the way of treating the cause of acid reflux. So historically, this been done as a surgical option, which is years ago we called it the fundoplication. And basically fundoplication, fundo comes from the fundus, and plication means wrap. So basically what's happened is that it used to be an open surgery where people surgically go in, the surgeon go in and wrap the top of the muscle, the top of the stomach part, which is the fundus, and create a new valve, okay, or strengthen that valve. If there is no hernia, if the diaphragm muscle has no wider opening that make the stomach slide up in the chest. So they just do the fundoplication. And the doctor who created it, his name is Nissen, and that's why we call it Nissen fundoplication. There are two different variants of that surgery, whether they do the wrap 100% or 360-degree wrap around the esophagus or less. So there are different versions of that. And that's usually the surgical preference, depends on what they see. If there is a muscle, if there is a hernia at that time, and they do hernia repair too. So that used to be done years ago surgically. Over the last several years now, it's done laparoscopically, like many surgeries now, done laparoscopically. So a few scars, belly button scar and few other small scars, they put the camera in and they do laparoscopic Nissen fundoplication or hernia repair at the same time. So that's been the standard for several years. Very few open surgeries done nowadays, and most of the time people go for the hernia repair and the fundoplication laparoscopically. Other ways of fixing the valve if there is no hernia, over the years there are many studies and many equipment and many ways of doing it, either injecting things inside the valve to strengthen, to bulk the valve, kind like when we put a Botox somewhere to strengthen the muscle. That didn't get much favor, but nowadays we have a newer, less invasive version of the fundoplication, and which we call it the TIF, which is what stands for transoral incisionless fundoplication. The T stands for transoral, meaning through the mouth. Incisionless because we don't do any scars. So it's an endoscopic procedure where we basically do the wrap to strengthen or create a new muscle. So these are endoscopic newer version of the older fundoplication. So these are things we start talking to the patient about once they either have refractory symptoms on medications, or their medications, or they are fed of medication and they don't want to continue on medication because of fear of long-term side effects, which we hear about and it's been on the media and on the research. Although some of the long-term side effects that we hear about are really an observational side effect that not really cause a relationship to the medications, but patients are still concerned about being on a medication. There are a lot of younger people who don't want to be on this acid reflux medicine for years and years, even if we tell them that it's safe. Just the idea of being on a medication for acid reflux for years doesn't appeal to them, which makes sense to many of us. So these are different ways of non-medication options of fixing the acid reflux, which is basically fixing the cause of what caused the reflux episodes.
Wonderful, thank you. Well, I am understanding, Lynn, that we have several questions that have come in. I'll go ahead, turn it over to you. Fire away.
Awesome. Thank you, Wendy. Great job explaining just the workup, what's involved in that, and what people can expect when they're going through this and trying to get that diagnosis. We have a lot of questions around the PPIs that you were talking about, the safety, using them long term. So thank you so much for addressing that. That's a large panel of these questions coming in. There's one question in here particularly. How can I tell if it's GERD or H. pylori? So back to kind of that evaluation and the importance of getting in and getting seen to understand what we're treating.
Correct. So H. pylori is a bacteria that sits in the stomach, on the surface of the stomach. It's known to be carcinogenic, meaning it can predispose people to stomach cancer. And it's known to cause ulcer in the stomach. So it can cause gastric ulcer, stomach ulcer, or duodenal ulcer, which is the first part of the small intestine. And it's very prevalent, meaning it's very widely seen. It's nothing in particular that you do eat or drink or do to make yourself get the bacteria. It's just there. It can come, there are more population than others are predisposed to, low socioeconomic class, immigrant from third world countries, and among others. But it is very prevalent. And once you see it, we usually try eradicate it, get rid of it, just because there is no good benefit from having it, knowing that it is carcinogenic and cause hepatic ulcer. Now, the people who have H. pylori do not have reflux symptoms. Okay, so just H. pylori itself does not give you acid reflux. Okay, it can give you indigestion, it can give you abdominal pain, it can give you bloating, gas feeling, and trouble after eating. That can be part of the symptoms of having inflammation of the stomach, ulcer in the stomach, and so forth. But there are two different entities. We tend to mix and match the symptom that's up here, okay? And really we needed to dig in exactly what do you mean when you feel not good after you eat? And that's important of trying to get into the bottom of that. And there is objective questionnaires for that. There is GERD questionnaires where you can give you a few questions and you'll tell you whether you have GERD or you don't have GERD. But people who have H. pylori need to get rid of it. And that's the importance of testing for that, evaluating to see whether you really have acid reflux or no. Now, we didn't mention some of the tests when we are when the symptoms are not typical. Like let's say somebody who comes in with a chest pain, somebody who has acid reflux and symptoms that are not getting better with, I'm doing everything, I'm eating the right thing, I change the way I eat, I take the medicine, I still have symptoms. So there are testing, objective testing that tell us that there is acid in unusual place. And that's where we call it the pH testing or pH monitoring. So there is medical pH monitoring testing. There's two different tests available. One is done through the nose. You go with a catheter down in the esophagus and it sits there. People go home with it for 24 hours where it's attached to a monitor and it measures the pH of the lower to the mid third of the esophagus. The esophagus not supposed to be acidic. It's supposed to be more of alkaline pH. And if it's unusually acidic, then that can be a diagnostic for acid reflux. The other test is done wirelessly. So there is a wireless capsule that gets attached to the mid to the lower part of the esophagus. And we usually do this during the endoscopy. So people who are suspected that they have atypical symptoms and I'm not 100% sure and we want to document that for sure, we plan endoscopy with the wireless pH testing. We call it the Bravo pH testing. So they get that done attached to them and they go home. There is nothing coming out of their nose. It's just wireless. They carry something like bulky cell phone, which you get the message for 48 hours. And then they deliver that equipment to us. That capsule eventually will fall off and after a few days, and then they don't have to retrieve it. So these are two objective ways of confirming for sure that there is acid reflux if we cannot see damage from acid reflux in the esophagus. So if I put the camera in and I look inside and I see Barrett's esophagus, for say, which is a complication, known complication of acid reflux, I don't have to confirm this is a confirmatory complication. When I go inside and I see erosive esophagitis, it means through the wall cutting of the esophagus, that's a lot of inflammation. And all of this inflammation means there is acid coming up. So I don't have to do pH testing to confirm. It's when there is, looks normal, but I have typical symptoms and I want to have an objective data to tell me that this is acid reflux. That's when we do that kind of. So that if I'm confused whether I have H. pylori, if I have acid reflux and the symptoms are not clear, then we test for H. pylori, and if we find it, we get rid of it. If the symptom gets better, then maybe it's just confusing picture. If it's negative, then we recommend some of the pH testing modality, one or the other. One of the also might be confusing with GERD. Symptoms get better some, but not 100% with medication, or it doesn't get better with medication, might be some motility issue of the esophagus muscle, which again gives some discomfort in the area here. And if I don't have the typical symptom of heartburn, then I want to test the muscle. I want to check whether the muscle moves the right way. There is muscle strength, how strong the muscle moves when I eat, and the direction of the muscle movement. It should move from top down. So contract, relax, which we call it the peristalsis as it pushes the food down. Now, some people have abnormal motility. So that's maybe a time where we test for esophageal motility study to tell us how that esophagus is working. So that's part of the advanced workup if there is a confusing picture, or down the road before going for surgery, let's say, or before going for an endoscopic procedure. I want to make sure that the muscle will work good before I tighten the valve, so people don't have any side effects. And I want to make sure that there is acid that comes up here if I didn't see it. So I can tell the patient that you really have acid coming up, even if your endoscopy looks normal.
Wonderful. Thank you for that. I think That was a great question, Patty, and I think it helped a lot of people understand the difference. But everything you're saying is really pointing to the need to get evaluated. If you're showing signs, having symptoms, getting in to be evaluated properly so your physician can work on the best treatment plan for you and whatever those tests might entail, like the ones you described. Some of the other questions here, again, are around PPIs. So Chad and Virginia and Connor and Dale, if we didn't address your question specifically, let us know in the chat and repost. But really just, are there risks on taking long-term, which you did address? There's some over-the-counter options comparatively that can help, but ultimately all are band-aids to what we know to be an anatomical condition most of the time. Another one we have here is from Connor is asking, why does the valve fail? Why does that reflux valve fail?
Some people have the valve fail just genetically. Okay, so it runs in family. A lot of people comes and tell me, oh, my parents have acid reflux, my grandparent has acid reflux. All of them were diagnosed with hiatal hernia before. It's kind of like, I have gallbladder problem, my mom has gallbladder problem, sometimes it's running in family. That's one thing. The valve fail by overusing it. Okay, so eating too much, indulging too much, obesity, pushing on the stomach is a cause of acid reflux or predisposed to acid reflux just by pushing and pulling on a muscle. Pregnancy tended to cause people to have acid reflux. Pushing and pulling on a muscle sometimes make it weaker. The presence of the hiatal hernia, okay? If you have a hernia and the stomach and the valve supposed to be here, but now the stomach is pulled up here, so the valve anatomy is not in the right position. It will pull and push. So these are kind of different reasons why the valve fails. There is a primary failure where it happened for no reason, or call it genetic or runs in the family, and there are other reasons that we do. So eating too much, eating and pushing and pulling on the stomach because of overweight or pregnancy can predispose to muscle failure. Also, there are some medications that can make the muscle relax more than normal and make people have acid reflux. And this is kind of, in a way, the easier way of finding out. And it's usually overlooked by many of us, but this is, sometimes it's an easy fix. There are many blood pressure medications, heart medications that makes the valve relax more than normal, like a muscle relaxant kind of. And if you do an endoscopy, you find no hiatal hernia and everything else looks okay, then by consulting and communicating with the cardiologist or the primary care, switching to different kind of medication might make the valve works better. So that's also something to consider.
Wonderful, thank you. And then one question is related to Barrett's esophagus. Am I eligible for the TIF procedure if I have Barrett's?
Okay, so Barrett's esophagus is, like we said, so there is unusual or atypical cells that replace the normal cells of the esophagus. And it's creep up from the esophagus from the lower part up. So sometimes we call it short segment Barrett's esophagus or long segment Barrett's esophagus, depends on how much of the esophagus is involved. Once those cells becomes precancerous or develop, there is a chance, it's a small chance, but it's still a chance of changing into cancer. The longer the Barrett's esophagus, the higher chance of changing into cancer. And the duration of untreated Barrett's esophagus carry higher risk of getting into cancer. Also, the biopsy is very important when you have Barrett's looking cells that we biopsy a lot in order to send it to ask the pathologist, are these only Barrett's, meaning are they only precancerous, or there are some early cancer cells that already start to develop, which we call it the dysplasia cells. And that's very important. So now once you develop into the dysplasia sequence that the patient is on the way to cancer. So that's when we stop and we say this Barrett's need to treat it. And again, it used to be big deal, but nowadays there are endoscopic procedures. We ablate, or we do ablation for those cells, meaning kind of, in a way, burning those cells, superficial burning of cells, and get rid of them so the healing of the esophagus occur with normal cells. So it depends on, to answer your question, it depends on how long the Barrett's is, how as a segment, how long of a duration of the Barrett's you have, and whether there is cancer cells or no. Most of the time, if there is Barrett's, we talk to the patient and we tell them, let's get rid of the Barrett's esophagus, and then put you to kind of the surgical procedure or the TIF in order to prevent the acid reflux. So kind of get rid of the complication and then treat the cause, or treat the cause first and then the complication. It depends on where are we and what's going to affect the patient's life first. So if you have a long segment Barrett's esophagus, in general, I tend to treat it first. If there is cancer cells, I tend to treat it first. If you have Barrett's for a long period of time, I tend to offer the patient to get rid of it first. Otherwise, there is no contraindication of treating the acid reflux, even doing a surgical procedure or the endoscopic TIF procedure, if you have a short segment Barrett's esophagus.
Very nice, thank you. So again, speaks to the importance of getting evaluated and allowing that treatment plan to progress based on what's found, because every person's different. But thank you for that explanation. The last one, Wendy, before I turn it back to you, since you were speaking of the TIF procedure, Mary Eileen is asking, how do you determine that a patient is qualified to have the TIF procedure?
Sure. So let's spend a couple of minutes talking about the TIF procedure. So again, it's a non-invasive test procedure in order to fix the valve. So there is an equipment, a device that goes on top of the scope and sits on top of the scope. We go through the mouth down. The patient is usually under general anesthesia just to be comfortable and just to relax the muscle and be in a comfortable, complete, relaxed state. And then we go inside, look first, do a good exam, and look upside down to the back of the valve. And from there, through that device, we pull part of the top of the stomach, which is a fundus, into the device, grab it, and turn the device to do what we call a wrap, or the plication. And do that repeatedly in a certain different position through the scope. And by that, we're creating a valve. Once you do the plication, we put a small we call it a fastener, which is kind of a medical plastic, and to keep that wrap in place. And we do that many times at different levels, and to create a nice sleeve or a valve in place. It takes probably less than an hour in experienced center and to create that valve. There is no scar, there is nothing from outside. Patients wake up. We tend to keep the patient overnight. It's still considered an outpatient procedure. Most of the centers will consider that even overnight is still an outpatient, just to observe, make patient comfortable. It's good that they know that they went to like kind of minimally invasive procedure or kind of surgery. So when you wake up, they answer the question, see them in the morning, they sip on some liquid, and they go home comfortable. So that's what we do for the TIF. Are you eligible for the TIF or no? How do we determine that? If you have acid reflux, diagnosed acid reflux, either with its complication or objectively by pH testing. If you do have a good muscle of the esophagus and it's working well, and if you've been on PPI for a long period of time, either it's controlling your disease, but you don't want to be on it, and or it's controlling to a certain degree, but you need extra help. We're increasing the dose, or so forth, then you qualify for fixing the valve, okay, the TIF procedure. So that's, we talk to the patient, we look at the whole thing. That's, we're talking about the GI part, or like the workup to qualify. The other reasons may qualify or not, that depends on your health in general. Most people, even if they might not be eligible for an open surgery or laparoscopic surgery, they might benefit from or might be eligible for an endoscopic procedure. So that's kind of, if you do have acid reflux and cannot get rid of the medication, then you should consider non-medical procedure, whether it's a surgery or the TIF. Now, why were you introducing TIF if we have a surgery that's known to work over for the years? Now, the Nissen fundoplication in any surgery, of course, surgeries have side effects. And it's risk of putting you to surgery and poking with infection. And even if small scars, there is still some sort of infection, although not common and less common than open surgery. By doing the procedure surgically, there are some GI complication afterwards. Many patients after the surgery, the Nissen, even if it's laparoscopic Nissen, they feel some complication that they don't get rid of. Their heartburn might get better, but they have, some of them have difficulty swallowing. It's known to have difficulty swallowing afterwards. Some people will have bloating and gas and indigestion feeling. They feel bloated. And many feel like, I cannot burp after the procedure. I cannot throw up after my Nissen. Since I had my Nissen, there is no way I can throw up, even if I feel sick. So I feel really bad that I'm bloated, I want to throw up, I can't. So these are not very rare and not everybody, but it's common to have a bloating, gas feeling on top of the stomach, like gas bubbles sitting on top of the stomach, indigestion after eating, difficulty swallowing if the wrap is done too tight, and unable to burp and unable to throw up. And believe me, I see a lot of people, this symptom is, for them, is very uncomfortable. Imagine if you want to throw up and you cannot throw up. This is very uncomfortable. So this side effects are not with the TIF. And why is that? The TIF wrap are made not to perform 360-degree full wrap. We do 270 degrees, like 3/4 kind of a wrap. And it's only when we wrap, we look from inside the stomach. So we basically wrapping what we see. It's different view from wrapping from outside. There is no scarring from outside the stomach. If you do any surgery, your body might react differently, and there might develop some sort of scarring at the site of the surgery from outside the stomach. And that might create to some stiffness or involvement of a nerve here and there that might make you have that feeling. And then that's why if you compare the studies that have compared the TIF procedures to the Nissen fundoplication, the laparoscopic, and they looked at good centers, experienced people who do both, they found out that there are less long-term side effects. We're not talking about just surgery complications. Long-term side effects, namely difficulty swallowing, bloating, gas feeling, indigestion, and inability to burp. Much less with the TIF procedure than the Nissen fundoplication.
Thank you, doctor. Thank you for that differentiation. I think that's important. Wendy, we do have a couple other questions, but I think they might be addressed in your close here with the post-op, et cetera. So Haley and others, if we don't address them, please post it here in comments again for us, and we'll get to them after the session.
Thank you. So thanks for the breakdown on the Nissen versus the TIF procedure. Can you tell me a little bit, we've talked about potential side effects. Can you talk about recovery and what that looks like after a TIF procedure?
So recovery after TIF procedure, like we said, the immediate recovery is we tightening the muscle, and we creating kind of wrap on top of the stomach. So people will feel uncomfortable. It's not more than just uncomfortable. And that uncomfortable feeling stays for a couple of days max. Maybe immediately before they go home while in the hospital, maybe they will receive 1 or 2 doses of pain medication. Very few people will have really sharp pains in that area. But most of people within few days, that heaviness on top of the stomach or like a punch feeling inside the stomach is gone. That's the immediate part of the pain. In terms of the recovery afterwards, is two parts. Recovery in terms of what to eat and what not to eat. People are worried about that. And recovery, like any other procedure, about exercise and return to regular activity. So if we talk about dieting and eating after the procedure. Now, remember, we are creating a wrap and we creating a new muscle, okay? Or we try to strengthen the muscle. So you want this muscle to heal in place and to heal healthy. So if we push too much through it, it's gonna just not gonna heal right. So we tend to be very conscious of what we eat. So we give people a slow progression of diet from before the procedure, a couple of days before the procedure. We tell them to be on liquid diet, okay, as if you're going for a colonoscopy, okay, just in preparation of what you're gonna see over the next few, or experience the following few days. And then after that, you just stay on liquid diet for a few days up to a week. And we progress that slowly from liquid to full liquid to soft diet. And by the time they see us in the office after the procedure or see the surgeon after the procedure, we put them into the regular diet. It differs from one person to the other. Some people will heal faster than others, but I'll definitely put the patient on full liquid diet by second week. So in 2 weeks, no solid before 2 weeks, because you don't want to go through all of this evaluation and the procedure and disrupt the healing. That's the dieting part. The exercise part or recovery and go to regular activity. You go to all your regular activity day 2, except heavy lifting and heavy pushing. And basically that's what it is. So you can drive back to work. If you are doing desk job, you can go back to your desk job. You can walk, you can do your regular home activities. So long you're not jumping, you're not pushing or lifting heavy object. And that, again, varies from one to the other, but I would say 4 weeks to 6 weeks, kind of, and the surgeons will tell you the same thing. Just, again, to keep that valve healing process to the full extent so we don't end up disrupting the healing.
Very good, thank you. And then can you talk a little bit about folks who are just, what are your patients saying as they come out of their recovery and they're GERD free? What are the reactions that you get?
Well, I get a lot of different kind of reactions, but most of the good reaction that they're actually happy, especially people who have been ignoring acid reflux for years, who've been popping thumbs for years, and before they come up and seek some advice. People who have difficulty sleeping at night, people who have the cough. Some people have cough for a long period of time and been to an ENT after an ENT and have all the over-the-counter anti-allergy medications and cough syrups and all of that stuff. They feel better. They actually feel better and they are happy. They come in and say, I haven't slept like this for a while. People who regurgitate, they really feel better. Especially those who have been, the heartburn is under control, but they're still having a hard time at night. Not only the patient. I mean, I had many patients come in, the family member come with them saying, I haven't seen him sleeping or her sleeping like this before. So it does really change the quality of life of people, not just by the heartburn. The other point is that they will be able to enjoy a meal. A lot of patients are not able to enjoy meals, even if they are taking medications. They are either worried that they might get an attack or they might not be able to sleep at night. And I'm not talking about enjoying meal like me, I'm going to sit down and eat a pizza. I'm just normal, a regular meal. Have little sauce on the pizza or like one slice of pizza. A lot of people are not able to eat that one slice of pizza just because they're going to suffer from that. So it's very important. Other people that are not able to work out, the people who have a hiatal hernia or people who really have a lot of regurgitation, they stopped working out. Every time they work out, every time they bend over, I have a patient who could not bend over and tie the shoelaces because every time they do that, they feel something coming back in the back of their throat. So these are the things that make you feel like, yes, the medicine, that procedure helped. And if you do that with a minimally invasive procedure, does not push them to surgery, they will appreciate it, and you really change their quality of life.
Marvelous. And since you mentioned the hiatal hernia, something that we haven't really touched on that I want to quickly is, you know, some folks wonder if they have a hiatal hernia and they have GERD, can they just have one addressed and not the other, and will it fix them both?
Right. So yes, thanks for this question because this is very important. Now we know that hiatal hernia is very common, okay? And hiatal hernia will disrupt the valve. So fixing the valve without fixing the hernia, you're not don't make sense or doesn't make sense. So what we need to do is when we fix the valve, we fix the hernia. So how do we do that? Gastroenterologists, there are some surgeons who do both at the same time, which we call it a combined technique, or the C-TIF, combine TIF and hernia. And if you go to a gastroenterologist who does the TIF, he does partner with a surgeon. So we usually ask the surgeon, and there are many surgeons now are open to the idea of having the hernia repair only, and instead of the surgeon doing the fundoplication, he does the TIF, or a gastroenterologist does the TIF, depends on your location and your center, and we do it at the same time. In my place here, I partner with a surgeon who, if I see hiatal hernia on my endoscopy or during the testing, he see the patient, he evaluate the patient for hernia repair, he comes in, and that patient with hiatal hernia will get laparoscopic hernia repair, which is small incisions. And while the patient in the same session, while the patient under sleep, in general anesthesia, I go in after he finished the hernia and I'll do the TIF part. So some people will ask, so if I'm getting laparoscopic surgery anyway, why don't I do laparoscopic surgery and let the surgeon do the Nissen at the same time? Now that comes to the complications we talked about Nissen fundoplication versus the TIF. So the hernia part, if you do hernia alone with a TIF versus a hernia and Nissen fundoplication, will carry the same difference in the long-term complications. People who get Nissen fundoplication laparoscopically at the time of hernia versus TIF at the time of hernia, people who have the surgical option twice at the two surgeries will have more likely to develop the bloating, the gas, the indigestion, the difficulty swallowing, and the inability to burp. And the surgeons also like the idea of minimally invasive. So more and more of the new the new practicing surgeons who trained to minimally invasive procedures will guide the patient to, if there is a procedure that's done endoscopically or less invasive, then you should go for that. I had patients comes to me years after Nissen fundoplications. Now remember, Nissen fundoplication sit there, but it has a lifespan. If you go for a surgery, hiatal hernia repair, and you do the surgical Nissen, the valve will stay there tight for a while. Eventually, it will loosen up. If you're lucky, it's 8 to 10 years. After 10 years, it tended to loosen back up. So I had patients come to me after Nissen fundoplication, and they start getting the symptoms back of acid reflux. And those people, we took them for their hernia is fixed, so we took them for a TIF, and they do well after TIF. So TIF, if you do TIF on a patient, it does not prevent them from getting another surgery. Let's say the small percentage of people who don't benefit from the TIF, if they want to go for surgery, they will be able to go for surgery.
Very good, thank you. So, you know, one thing that you touched on that I wanted to mention too was oftentimes folks who, you know, are looking at a potential, you know, life-changing procedure like this don't necessarily even connect until afterwards, you know, after you see them post-operatively, that it has not only impacted them, but it has impacted their loved ones who live their daily lives with them. So I wanted to point out how wonderful it is to hear, you know, that your patients are reporting that, you know, they're able to sleep, they're able to eat, they're able to enjoy a meal, and positively impact those around them too. So thank you for that. Lynn, before we close up, any questions that we need to get to?
It looks like we've addressed most of them. The only thing that I would say might be important to address, there might be some misunderstanding regarding properly working esophagus and the ability to proceed with a procedure. And I think you explained that there is that potential. And again, it might just depend on that evaluation. But if you'd like to address that real quick, that's for Rick.
Okay, so in order to strengthen the muscle, I mean, you can strengthen the muscle anytime, but you want to make sure that the muscle will work well, at the same time cutting down the risk of failure of the teeth. So you might create a good valve, but if the muscle of the rest of the esophagus is not working good, the patient might feel different symptoms afterward. They might feel that the food is stuck. Why? Because I created a valve here, but the muscle is weak, not able to push the food normally through a normal valve, but it was able to push the food through a weak valve. So that's why the muscle has to be a normally functioning muscle. So people who go for TIF or Nissen fundoplication, part of the standard of care is to do an esophageal manometry or motility test to make sure the muscle on top of the valve is working appropriately. Because if it's not working appropriately and the valve is loose, food is going to go through it. But if I tighten that even to a normal appearing valve or functioning valve, the muscle is weak, it might not push the normal food through. So that's the part that's very important. That's part of the workup to before surgery or before the TIF.
Thank you. And then lastly, Paul is asking, you mentioned the inability to belch and vomit as a side effect of the Nissen fundoplication. He's asking, would vomit reaction break the TIF wrap, and would someone need to stay on anti-nausea medications long-term after having a procedural intervention?
Not prophylactically. We're not doing it to prevent it. If somebody, for whatever reason, feel nauseous, and we'll give him medications and we'll guide him through how to prevent that and treat that. If you have nausea for a day or two and it's not vigorous vomiting, most likely you're not going to disrupt the TIF procedure. But if you go in a spell, yes. So we keep that individualized based on the patients and based on the background and the history and how he reacts. And that's also important, at least for me and for many other providers, that first 24 hours, okay, that overnight in the hospital will guide us on how the person will react going forward. And you answer this question. If somebody waking up in the morning starting to get nauseous, I'm not feeling well, I might send him home a few days of anti-nausea medicine to give him comfort, number one, and number two, to prevent any disruption of the procedure. and so forth.
Wonderful. Thank you so much for those thorough explanations and addressing everyone's questions here tonight. Wendy, I'll turn it back to you.
All right, Dr. Sargios, thank you. As we close out tonight, you know, we like to finish up by giving you the floor. And if you have any parting thoughts that you'd like to offer to anybody who is out there suffering, maybe wondering if they should be seen, what their next steps are, or anybody who's considering the TIF procedure, what do you have for us?
Well, I just want to end up by saying that reflux, having a little bit of indigestion every now and then, or episodic once a week, or every now and then if you party or you go to an occasion, or you eat late meal, or have a drink here and there, and you're getting some indigestion or heartburn, that's okay. But if you have more than that, there is no reason to not to be evaluated. You should be evaluated, because it is a disease, and that's why we call it GERD, and the D part is a disease. It's different than I have low indigestion. So it is a disease, and once it has a disease, then it has a complication, and this complication can be deadly complication. If we reach into esophageal cancer, it's not an easy cancer to treat, and you don't want to have that. For something that we could have prevented it by early evaluation, see if you are at risk of getting into bad disease, and see if anything that we can do to prevent that. And even if it's a small procedure that will help change your disease progression, that's number one. And number two, even if you're not going to go into that sequence of disease progression, just having different quality of life and able to enjoy normal eating, normal sleep, normal daily to daily activity, and not be on a medication for a long period of time, I think that's worth it to be evaluated for. Not everybody will get TIF, not everybody will get Nissen, and not everybody will need the proton pump inhibitors or the PPI or the purple pill for life. So just get evaluated and make a wise decision, you and your gastroenterologist or the provider that you're seeing.
Wonderful. Well, we really appreciate the wealth of information that you have provided for our viewers this evening. This has been a fabulous TIF Talk, and I hope you'll be with us again. For those of you out there who are wanting to consult with a TIF specialist, like Dr. Sargios, please visit our physician locator at gerdhelp.com. There you will be able to go ahead, enter in your zip code, find a physician in your area, and simply contact them at your convenience. Also, if you'd like to start helping out your physicians a little bit more, we have a new tool. It's a patient education mobile app called GERD Help. You can download it on your iOS devices or your Android devices. There you can not only read informative articles, see videos, but also there is a journal for you to enter real-time symptomatic characteristics that you have. This will help your doctors understand what's going on a daily basis, even at a specific time, and you can help them decide the best treatment pathway for you. So we hope you'll take advantage of that wonderful resource, and we want to bid you a good evening. Dr. Sargios, Christian, and Lynn, thanks so much, and we'll see you next Tuesday for our next TIF Talk. Have a great evening, everybody.